If you're planning to move to Saudi Arabia, you will have a great time and an amazing experience. But be careful, because the health authorities in Saudi Arabia are very strict and only allow a handful of medical insurance providers to offer insurance coverage. An important fact for you to consider is that your health insurance needs to be compliant in Saudi Arabia to get your visa process accepted, and in a few years down the line get your visa extended. We understand that those rules and regulations can be very, very difficult and very overwhelming to find the proper provider for yourself. So please feel free to get in touch with us in Global Assurance anytime. What we do in Global Assurance is we try to find the best solution, the best coverage, specifically to your needs of yourself and maybe of your family. Medical insurance offers a large variety of different benefits that you can choose from. So it's important not only to find a policy that covers you according to your requirements, but also find an insurance provider that is authorized to sell medical insurance for Saudi Arabia. As I said, feel free to get in touch with us anytime if you need advice on health insurance in Saudi Arabia.
We are fortunate today to have Terry Singleton as our speaker. He's a lifelong resident here of Orlando and almost a Florida native. Terry's a trusted advisor with more than 20 years experience in employee benefits and agency management. Since 1990, he has effectively helped employers of all sizes across multiple industry sectors analyze costs, identify financial drivers, communicate, brand, and implement benefit programs that meet their financial objectives. He understands the Affordable Care Act and is transforming employee benefits. As a way of transforming employee benefits, and appreciates the obligations and opportunities it presents for employers. He is positioned to help his clients predict, prepare, and comply with its coming changes. Terry completed his bachelor's degree in business with honors from Western Carolina, but he also has attended 4 other institutions and has major degrees, and as I read the alphabet soup, I think you'll come to recognize that in just a moment. He's licensed as a health, life, annuities, and general lines licensing agent. Terry holds advanced financial designations, allowing him to assist his clients, including Certified Financial Planner, CFP, Registered Employee Benefits Consultant, and REBC, Certified Life Underwriter, CLU, Certified Fund Specialist, CFS, and Registered Health Underwriter, RHU. Now, as an agency partner at Sile Insurance Group and leader of the Enterprise Team, Key Account Employee Benefit Advisory Team. Sile is the second largest privately owned insurance agency in Florida and is based in Altamont Springs. He also has some friends here with him from Sile. I'm probably not going to mention everybody here, but I know that Lou Mitchell, the general manager, is here. Lou, thank you. And Larry McLean, the director of sales. So welcome to you and all of you guests here of More Of and our vendors. At this time, would you give a nice warm welcome to Terry Singleton.
Thank you, my friend. Unfortunately, I don't have the funny jokes and quotes that Hank has, but he has more. Okay, we're all set then. He has more. Healthcare reform, your favorite topic. I wanted to thank Hank and Chuck and Vicki Van Gorder and the More board for having me back. I was actually the first speaker for this group, and it has grown and done great things, and I am very proud to be back and honored to be here. Healthcare reform is certainly a very large topic and one that affects many, many people. The ramifications are huge. I spent a lot of time talking to a number of groups about what's happening in healthcare reform. It's been my privilege to represent a bunch of groups about that. And I really enjoy speaking, so giving me the mic is a dangerous thing. We're going to go over today a number of pieces. One is the legal status of the law, which plans must comply with the law, grandfathered programs and what that means, reforms currently in place and how that works, the 2013 and 2014 deadlines, how all of this will impact cost, and still leave time at the end for questions and answers. So my job today is to go through 2,700 pages of actual statute for you, explain the whole thing to you, tens of thousands of pages of regulations for you, so when you leave, you know all about everything, right? We're going to actually move pretty quickly through a bunch of these pieces. Oops. There we go. Before we get moving into that, let's agree to a couple of things. The law was hotly debated, right? There were people who were for it, people who were against it. It is so large and so encompassing, I think we can all agree that there are certain pieces that we like and certain pieces that we personally do not like. Agreed? Okay. Let's talk about today what is, not what should have been, what could have been, what should be. Can we all agree to that? Okay. Let's look at just those pieces and we'll be good to go. All right, everyone stand up. Everybody up. Little survey. Just to get a feel for what you guys understand about healthcare reform, we're going to do this little survey, and it's going to be like this. Those of you who really don't have much idea about healthcare reform, you've heard it talked about in the media, but really that's the extent of your entire knowledge. On a scale of 1 to 10, you would be a 1, 2, or a 3. If that's you, have a seat. Okay? Those of you who know a little more than that, you've read some things about it, you've been involved in a presentation or two, you're a 4 or a 5 or a 6 on the knowledge scale about healthcare reform. If that's you, have a seat. If you are a former legislative chairman on this topic, and there are 2 in the room I know of, or if you are a person who has a lot of knowledge about healthcare reform, have a seat. Okay, anybody left? No. Thanks. That gives me an idea of how to gauge the presentation. We have a lot of things to cover. I'm going to overgeneralize a number of pieces. Some of the things we're going to go through, I'm not going to explain to you all the ins and outs of it. For example, one of the affordability rules is 9.5% of income is the most that an employer can charge an employee to be affordable. There are 3 tests behind that in pages and pages of regulations. I'm not going to go through all that today. I can't do that much. My goal today is to be able to educate you simply about a couple of the pieces on the law, not to go through every little nuance of the pieces. If you're an employer group and you have that need, see a qualified advisor, they can help you with that. Any questions on that? Everybody good with that? Okay. Has anyone ever seen the game Plinko? Plinko is the game where you drop the coin at the top, and as it goes through, it hits all the little pins, and it bounces crazily all over the place, right? Legislation on this bill has been a lot like Plinko. The things that were passed were not necessarily intended to be passed. The things that were done for expedience, but weren't necessarily thought totally through. And that little coin has bounced all over the place. And in my opinion, it will keep bouncing all over the place for the next few months as this law becomes implemented and the regulations come out about it. Oops. We all know that the Supreme Court has ruled on the law. The law was passed March 23rd, 2011. And the Supreme Court had this big ruling about it. They ruled that the individual mandate is legal, meaning that all Americans must have insurance coverage as of the 1st of next year. And if they do not, they will have a tax or a fine they have to pay because of that. Everyone's clear on those pieces. There's been a lot of discussion recently about can the Republicans repeal the law and replace it? Can the Democrats veto and stop that? Which pieces will be changed in the law? Senator Backus, Max Backus from Montana, Democrat, recently said to Catherine Sebelius, who's the head of HHS, that the law the regulation he saw coming up was a train wreck. He said that in a Senate committee meeting 2 weeks ago. That's a Democrat talking about the law. He was actually one of the people who implemented the law and was instrumental in creating it. So there's a lot of issues on both sides about this law and what's going to be happening. It again is a very large piece of legislation. We do expect there to be additional regulations coming out. A lot of the things that have happened will be changed or have been changed. The Congress remains divided on this law, and but we don't expect there to be any major revisions to it. The things that have happened so far have happened because people have very strong views on this law. As an employee benefit advisor, I have been in meetings where people have cried and been very emotional. Healthcare reform talks about health insurance. It talks about access to quality medical care. And that becomes a very personal issue to a lot of people, and a very, very important issue. It talks about the health of their children, of their families. And so you get a lot of emotion in things like this. And that's the thing that we have to look at and be respectful of as we move through the process. Agreed? Clarity. In this discussion I've had with different groups, people oftentimes leave and think, gosh, the sky is falling. This is huge, it's massive, it can't be done, it's going to be very expensive. It's getting better, guys. What's happening in this law is improving. A number of pieces have been repealed, like the free choice voucher, like the Class Act. It's becoming more and more clear. So while in the beginning it looked to be unfathomable, couldn't be done, impossible, too expensive, too huge, as we move through the process, it's becoming more and more doable. And we're seeing more and more meat on the bones, more and more ability to have clarity in this. Initially there was a provision that was going to require that everyone issue a 1099 to any vendor. Remember this, right? Okay, that's gone away. So it is getting better. We've postponed the non-discrimination rules. We've postponed the W-2 requirement for HSAs. How do you calculate the value of an HSA? Well, really, you can't yet. So they came out and said, well, we're going to postpone that. You don't have to put that on the W-2s yet. We talked about the exchanges coming up and the notices for that due in March. They postponed that. So it's becoming a lot more feasible to actually do more things in this bill. There's also a number of safe harbors that have come out. One of the things that they had talked about was to calculate the family income to be affordable under the Act. Well, how would an employer calculate the family income of an employee in advance of when they actually earn that? Right? Kind of hard to do, but that was the law. Now they have come out with safe harbors that make a lot more sense than that. So as we're moving through this, there are things that are becoming a lot more clear and a lot easier to understand. Which plans have to comply? Essentially, medical insurance plans. We're not going to go through tanning beds. We're not going to go through fast food menus today on healthcare reform. It's part of the law, I agree, but not part of this presentation. We're going to talk about healthcare plans, and it involves fully insured programs. It involves self-funded programs. It involves individual medical programs. It does not involve life insurance. It does not involve property and casualty insurance. It does not involve dental and vision plans that are not part of a medical plan. So a number of things are not part of this law. It's specific to medical insurance programs, okay? We were told initially that if you had insurance that you liked, you could keep that, right? Well, as things changed, that changed too. Essentially, there's a qualification called a grandfather status. And if an employer has not changed their plan, essentially in any material way, raised a copay by more than $5, increased the employee cost share, done a number of things, and that the plan had stayed the same, then technically that plan would be grandfathered and would not have to comply with a number of the pieces in the new law. One of them, the most important of them, the most costly of them, is the no-cost preventive care, meaning that an employee goes in for preventive services, and there's no employee cost share. They don't pay a copay, they don't pay a deductible, they don't pay co-insurance. It's essentially free to the employee. And that's required under healthcare reform, but you can still do that under a grandfathered program. Well, the way it actually works is that if you're Blue Cross or you're Aetna, you're a major insurance company, it's very expensive for a small group or a smaller group fully insured program to be able to have two plans. One plan that's healthcare reform compliant for those plans that are not grandfathered, one plan that is grandfathered and is the same as it used to be. Administratively, that's expensive and that's burdensome. So they don't do it that way. The insurance companies have largely come out with one program, and that is a healthcare compliant benefit program. So most all fully insured programs are no longer grandfathered. They've changed to the healthcare compliant program, okay? Reforms that are currently in place. We're going to go through a few of them. There are a bunch of things that have changed. We're going to go through a few of those pieces. Dependent coverage to age 26. This essentially means that if you have a child and until they become age 26, they can be on your medical insurance program. Even if they're married, even if they have a job, even if they don't live at home. So they can still be on your program. If they have, and there's a number of rules to this, but if they have access to employer-sponsored coverage, they work and their employer offers them medical insurance, this may not apply. But in most cases, they can be on your program now, and that's part of the current rules. There's no lifetime restrictions, so there's no lifetime benefit max. Used to be a group policy had a maximum benefit of $1 million or $2 million. Those are gone now. Things that are pre-existing for children, I think that is pre-existing is a thing that you knew about before you bought the insurance policy, okay? And for children, the insurance company can no longer limit what they cover because of things that are currently known when they apply for coverage. Is that clear? Everyone get that? For non-grandfathered programs, again, there's no cost share for preventive coverage or preventive care. And preventive care means a lot more than it used to. It's not just a regular routine annual exam. We'll get to that in a minute. The appeal process has changed to have some outside appeal options with your insurance company. There's no reimbursement for over-the-counter medications unless you have a prescription under a flexible spending account. If you have a prescription for aspirin, you could still deduct it. Don't know why, but that's the rule. Medical loss ratio rules. These are the rules that limit what an insurance company can make for administrative charges. It's 15% in the large group market and 20% in the small group market. So it limits how much profit they can make. It also limits what they can spend on administrative charges. There's good and bad to this. The negative side of that is limiting an insurance company's ability to have fraud prevention programs, wellness programs, things like that that are not part of the law, are part of the medical loss ratio and are part of the admin cost. That could not be good. The other piece is that telling an insurance company that if you charge more money for premium, you'll make more profit may not be the best idea, in my opinion. W-2 reportings, that's happening now for employers that issue more than 250 W-2s per year. Oops. 2013 deadlines. New thing out called Summary of Benefit and Coverage. And this is a new, fairly large piece that's required by all medical insurance programs, fully insured and self-funded. And what this says, the idea behind this is the government felt like there needed to be a uniform way to explain coverage to an employee. For example, when we do meetings for open enrollment for employers, we may have a summary of benefit from one carrier that could be 27 pages. I know of one. Another one could be 4 pages from a different insurance company for a plan of benefit. The government felt like that was confusing and that they wanted to have more of a uniform template standard. And so they're requiring that this summary of benefit and coverage be issued to every employee, and there's very specific rules behind this. The insurance companies may also issue their own summary of benefit, but this template benefit summary has to also be issued. It's for all plans beginning 9/23/2012, has to be issued the first day, and there's rules for when the health plans, the insurance company or the supplement program has to give that to the enrollees, and when they have to give it, and the insurance companies have to give it to the group plans. But it will begin the open enrollment beginning 9/23/2012 forward. An SBC, summary benefit and coverage, has to be given by the insurance company to the health plans on application, on the first day of coverage, when they renew the policy, or on request. The plans must give the SBCs to the enrollees when they enroll, annually at renewal, 30 days before. They have to give that under a number of different situations or on request, first day of coverage, so forth. So this is going to be a new requirement for employers that is currently coming into effect that will be a little more confusing to employers and employees, but it's where we're at right now. Okay? This was very scary to me when this first came out. This is a 60-day rule that says, it's part of the law, it says that if there's going to be a material change in a group policy, then that has to be announced to the employees at least 60 days in advance. Well, on a renewal, you can't possibly do that, can you? Because if you underrate the numbers for the renewal, and you do that 6 months in advance, and you give the employer time to shop for other coverage, and then they're able to make a decision and enroll the employees, I mean, you'd begin every renewal 6 months after you renewed it. That would be nuts. So again, back to clarity. Everyone panicked. Government came back and said, well, that's the rule. That's what the law says. But we're going to change the regulations behind that to say that it's 60-day notice of any material change except renewal. So if an employer wants to make a change to their group policy during the plan year, change the cost share, change the benefits, they have to give the employees 2 months notice of that, but not on renewal. So it makes a lot more sense that way, right? Preventive care for women. Preventive care is for men and women now, and there's no cost share for non-grandfathered programs. But preventive care means a lot more than it used to. The thing you've heard a lot about is that preventive care must be provided at no cost share for contraceptives and contraceptive counseling. A lot of issues with that with different churches and religious groups. It also involves breastfeeding supplies and counseling. That's now preventive care. Folic acid for pregnant women is now covered at no cost share as preventive care. Certain drugs are covered as preventive care, no employee cost share. Can be good for the employees, can also raise the premium. Other things are diabetic screenings for pregnant women, the sexually transmitted infection counseling. Number of things that were not thought of as being preventive are now thought of as being preventive care at no cost share. Okay. One of the pieces to this to pay for that is a tax on high income earners. They're going to change, they're changing the Medicare tax to increase that by 0.9%. The employer has to deduct it. The employer has to submit it. The employer does not have to pay it. The employee pays that additional money. So the change in the way the taxes work on payroll deductions, and they're going to increase those numbers. It only applies to earners who have of income of $200,000 individual or $250,000 for a married couple, for a family. Okay? I believe that's gross wages, yeah. FSA limits. FSAs are programs, are flexible spending accounts. They're part of a cafeteria plan under IRS Section 125. Essentially, this is the program that allows an employee to be able to tell the employer that they want to put certain dollars into the FSA to be able to use those pre-tax. Dependent care is part of that. Medical reimbursement is part of that. A number of things can be part of that. They're going to limit that to $2,500 per year. The famous piece of this legislation before this was the old-fashioned use it or lose it. Anybody heard that term? Okay, that's the FSA. And in the FSA, the people that get to keep the money, if you as an employee lose it, is the employer, right? On the other hand, if you as an employee are putting $100 away into your FSA, and on the first day of the plan year, you want to use $1,000 of benefit, they get to upfront those dollars, okay? So it changes the liability for the employee and the employer, and it limits the amount of money that the employee can pre-tax through this. It does not apply to dependent care, though, so that's still available without a limit, unless the plan puts a limit on it, okay? This one I like, Patient-Centered Outcome Research Institute. This is a government program that's going to cost $1 per person, and we'll increase it to $2 and then go up from there. But this is going to fund a program to help figure out what works, essentially. If a person has prostate cancer in one part of Orlando, they may get one treatment. A different part of Orlando, the same type person, same age, same conditions, may get a different treatment. This program is designed to look at what was effective and be able to communicate back to the people and to the physicians, what actually is working in the market across not only the city, but across the state and the country. So that may be a good thing. It will increase the fees, though, by a little bit. Notice of exchange. Exchanges are not out yet, but we're required to issue a notice of the exchange to all employees so they would know about the exchange. However, because they aren't out yet, the government has said we don't have to do that yet. They postponed that requirement. They have to include a bunch of pieces. We expect more guidance here shortly when the exchanges are actually launched, but there's nothing really to announce because they aren't out yet, and some feel like that they could be delayed. We'll wait and see. 2014 deadlines. All right, guys, the individual mandate. Everyone's heard about this. These are the numbers. In the first year, if a person chooses to not have medical insurance coverage, they will have to pay a fine, a tax of $95 or 1% of their income. Okay? In year 2, that will go to $325 or 2% of their income. In year 3, it gets more serious. It's $695 or 2.5% of their income. This is now required that every American either pay the tax, the fine, or they buy medical insurance coverage. For a child, it would be half of that number. Okay? So you'd have an uninsured child, then the parent would owe half of that number, and you can't owe more than 3 times that number for a family. That will be in effect the end of this year. Everyone clear on that? Yeah.
That's an annual cost.
Annual cost, correct. Per person. Per person, annual cost. Well, it's limited to 300%. So if you had a family of 6, you'd have one for the wife, one for the husband, half for each child, but no more than 3 times for the family.
But it's whichever is higher.
Yeah, whichever is higher. So So depending upon your income, your fine could be higher on a percentage of income than it would be on the actual dollar amount. Okay. The IRS has hired, depending on who you talk to, between 10, 16, 18,000 new people to try to enforce that provision. How they will exactly do that hadn't been written yet that I know of, but that's the way they're going to try to do it.
What about no-income earners or low-income earners or homeless or these types of...
They would still be required to either have insurance or pay the fine. And if they have insurance, then they could get a subsidy through the exchange, or they could go to Medicaid and get coverage there if they're below 138 of the federal poverty level. Okay. Good questions. Healthcare exchanges are supposed to be established by state. In Florida, we have said as a state that we would not do that, and that the federal government will have to implement a exchange for this state. We've actually gone as far as to change the way medical insurance policies are rated in Florida to abdicate that responsibility to the federal government as well. So the Fed will be responsible for not only the exchanges, but for approving non-exchange medical insurance rates as opposed to the Office of Insurance Regulations, who had done that before. Florida has essentially said, we want no fallout from this, so we aren't going to touch that. Individuals can get a subsidy from the exchange. That will be based upon income and will be based upon the availability of employer-sponsored or government programs for that individual. I'll get to that in a minute too. That's going to be a whole lot of fun. Employer responsibility. Okay. This is a hotly discussed topic. What exactly does an employer have to do? There are a couple of tests for this. One is the employer a large group employer or a small group employer? That's a very distinct line in the law. They're going to look at the number of full-time equivalent employees to determine the size of the group, not the penalty, but the size of the group. So one test is the number of full-time equivalent employees an employer has to be large group or small group. Does not apply to whether you're penalized. It just applies to whether you're large or you're small, okay? And the other piece is if you are a large group, then are you offering affordable and qualified coverage? Affordable is essentially going to be 9.5% of an employee's income. So if they make $10 an hour, it's going to be 95 cents. That's what they'll be required to pay, no more than that, toward their medical insurance cost. Qualified is going to be 60% benefit. So if you had a program that's going to pay 60%, the employee pays 40% of any cost incurred, and there's no limit, no copays. That would be a pure 60%. Most plans will meet that now. Most plans would be qualified for under that test as a large group employer. In small group, the rules are different. If a large group employer does not do that, they don't offer qualified and affordable coverage, then there are certain penalties that could be in effect. One of them says if you don't offer qualified and affordable coverage, then you'll pay $2,000 per person per year. Now keep in mind that's an IRS fine, a tax, which means you cannot deduct that as a business on your income tax. So you're paying $2,000 plus your income tax rate, for example. If you're in a 30% bracket, you'd effectively pay $2,600 for that, okay? It does exclude the first 30 employees, which would help a small employer. If you do offer coverage, and you're trying to offer affordable and qualified coverage, but you have some employees, more than 5%, that slip through the crack, and for them, the coverage is not affordable. It's not qualified. Say you get a hotel like this, certain people are full-time, but their income is lower and they're paying more than 9.5%, right? Then, and they go to the exchange and they get a subsidy. Then you as an employer would pay $3,000 penalty because that employee went in to the exchange and got a subsidy when you offered coverage, but it was not qualified and affordable for that employee, okay? If one goes, you would get fined for all, typically.
Repeat the question.
If the question was, go ahead.
You've answered If you get fined for all your employees.
Would you get fined for one employee or all employees?
Depends on which one. If you could repeat the question back, so we'll pick it up on that.
Okay.
The question was,
The question is, if you have one employee who goes to the exchange and gets a subsidy, does that mean you would be fined for all the employees in that category? Probably, yes. Okay, pay or play. I can show you some really neat programs that cost $10,000, $20,000, very colorful, great graphs on pay or play analysis. I've also done that on a napkin with an employer before. So pay or play is the employer's choice on whether they want to offer medical insurance coverage or pay a fine. And real briefly on that question, there are things to consider. If you're an employer and you've got 100 employees, right? You're offering medical insurance to those 100 employees. Why are you doing that? You did that 3 years ago. You did that 3 years ago. So why are you currently offering that coverage? What is the business reason that you have as an employer to be doing that? Most employers would tell you that they offer coverage to recruit, to retain, and to reward their employees. Because they could have dropped coverage 3 years ago, saved a boatload of money, but they didn't. Why? Because they're getting a business return on that investment. So for that employer, the fact that they'll be penalized for not offering coverage does not change the fact that they have to have the coverage to recruit and retain and reward their employees. So they're not going to drop coverage. They can't. Okay? For an employer that is not currently offering coverage, then they get a choice to make. Is it more beneficial to them to offer a group program and be able to retain, recruit, and reward employees and pay the cost of the insurance coverage, or is it better to not have any coverage and pay the fine? That's their choice. What it does do, though, is if you have an employer, a hotel, that does not offer any coverage, a hotel that does offer coverage, then the employer that does not offer coverage has to make a choice that will at least in some way level the competitive playing field against the hotel that has been offering coverage. You see? So most of my clients who are offering coverage don't necessarily see this as being a negative because their competitor who's not offering coverage have to increase their cost to be more competitive with my employer. Okay? Did you get that? Things to consider would be the waiting period changes. We'll get to that in a minute. The employee cost share. Will more employees join the program? Things like that.
on the payer play,
Mm-hmm.
is that for all employee groups?
It's for 50 or more. 50 or more employees.
That test, is that going to cost money to provide that test?
There are groups out there that are charging tens of thousands of dollars for that test. Yeah. Real briefly, I know we're running short on time here. I don't have enough time for questions. Employers view compensation as being a package in most situations. And if one piece has to increase in cost, they're going to decrease another piece. I've seen employers do some pretty dramatic things along that lines. This is a graph about that. And essentially, the employers plan to pass along the cost of any increases to the employees, either through lower wages, no raise that year, so forth, or through increased insurance costs. Premium assistance. You can get a subsidy through the exchange if you are not eligible for a government program like Medicare and Medicaid, and you do not have access to qualified and affordable coverage. This is going to be a huge shock, in my opinion, to many people. People out there who think that this is going to be free to them, yet they're currently working, they have access to qualified and affordable coverage, they're making $10 an hour, they're asked to pay 95 cents an hour toward medical insurance coverage, and they can't do that. That didn't work for them. They can't do that. Yet, because they declined medical insurance through their employer, themselves and their dependents get no subsidy through the exchange. Okay? So because they're offered coverage, they get no subsidy through the exchange. Okay? 2014 changes, there's going to be nothing that will be pre-existing for anybody at that point. There's going to be wellness programs available to employers who can change the premium that they charge the employees between 30 and 50% based upon wellness programs and based upon smoking cessation programs. They're going to limit the out-of-pocket expenses and the cost share. A waiting period cannot exceed 90 calendar days. Many waiting periods are longer than that, but in the new world, waiting period cannot exceed 90 calendar days. Not the first day after, but 90 calendar days. Guarantee issue and renewable, no annual limits on essential health benefits, and there's going to be additional premium rating restrictions. Cost. Let's talk about what this is going to cost by segment. Does anyone here sense skepticism? Okay. The CBO says the costs are going to run $1.165 trillion over 10 years. This is an expensive thing. There's going to be $55 billion over 10 years in penalties that they plan to acquire. The direct cost for employers, it's hard to estimate a direct cost for an employer. There are certain taxes and fees I didn't go through that are in the law that are either to the insurance companies or to the employer-sponsored programs directly. And we figured those are going to be between 4 and 5% of premium. The big changes will be in the underwriting and how they're being written. Things like no pre-X. No pre-X is a great thing for certain individuals, but if you allow nothing to be pre-existing, then you'll definitely raise the cost, right? Individual coverage. Currently in Florida, an insurance company can decline an individual application. They can choose to not cover a certain condition, but issue the policy. They can rate the policy higher in some situations because of certain conditions. All of that will go away. They cannot pre-exist anything. They must take everyone who comes to them, whether they have a current condition or not. They cannot limit the out-of-pocket maximums. They can't have a dollar amount limit. They have to include what they call 10 essential health benefits. And there's additional fees. We project, I've seen one carrier go as high as 116% filed rate, not theory, but actual things they're filing for 1/1 in Florida. But I would project that individual medical rates would raise at least 50% because of these rules. So that's the cost associated with what they're doing here. In the small group market, right now in small group, you have a discount of 15% available to groups that are healthy, and a 15% increase in cost for groups that are unhealthy. That goes away. Right now you can rate according to gender, male or female. That goes away. Right now you have the ability as an insurance company to issue rates that run about 10 tiers. So the cost for the youngest person age 18 to the person who's age 64 can be up to 10 times different in rate. The new rule is 3-to-1. 3-to-1 says that the younger person will pay a lot more, the older person will pay a lot less in order to get into 3 rate tiers, no more than 3 times the youngest to oldest, okay? Big change. If you're a small group, you're mainly male and you're healthy, then you're going to change to being gender neutral, which will increase your costs. You're going to change from being 15% below state filed rate to being at state filed rate. You're going to change from a 10-to-1 age band ratio to a 3-to-1 ratio. So essentially, your rates are going to double. That's the way it comes down to. An older group that's more female, their rates could come down. They're also going to change the waiting period for this. They're going to impose a rule that says that in the fully insured small group market, the max deductible for an individual can be $2,000 or less, no more than that, okay? They're also going to impose some maximum out-of-pocket costs that would be the HSA limits as they increase. So the total increase in cost we project for the small group market in Florida would be between 25 and 50 points based upon these rules. Large group gets out a little easier than that. Because they're large group, they are not part of the 10 essential health benefits. They don't have to comply with that. They don't have to comply with the max deductible. They can have a deductible higher than $2,000 per individual. They can, they will have to deal with the pay or play shared responsibility fine based upon if they offer qualified and affordable coverage or if they don't. We project that their cost will be between 15 and 25% higher because of these rules. Okay? You will have questions. You can get me on the Moroff forum, right, Chuck? You can email me at this address here, tsingleton@silent.com. You can call me on this phone number. But when you have questions, let me know. There are a number of things I did not cover, a number of things I went through very quickly and didn't dig into all the details. So if you have specific questions about your employer group, seek an advisor who can help you with that. Any questions? Okay. Vicki Van Gorder.
My question is, when we look at healthcare and we look at small groups versus large group, what's the percentage of each of them?
Cost increase?
Well, yeah. As far as the geographics, as far as in this room, we know that small employers are a huge employer base in the country. So when we look at small groups and their changes versus large groups and their changes, what's the percentage of small groups in the country and large groups?
I don't know the exact percentage. Let's look in this room. How many of you are with an employer group that you think would be less than 50 employees? Okay. How many are with a group that would be more than 50 employees? So you've got about a third above 50 and about 2/3 below 50 in this room. I think you'd see across the state a lot more small group as a ratio than that. But small group will be hit a lot harder because they're going to have the 10 essential health benefits. They're going to have the 3-to-1 ratio. They're going to have the no gender rating. They're going to have the no change for medical health of the group, 15% higher or lower. One state has got a discount or increase based upon cost of 65%. Think about those guys. So in small group, it'll be a lot more expensive.
Just a follow-up question on the small groups. Can the small groups become a big group? And can we also purchase insurance out of state?
That's one of my favorite questions. Out of state, there may be regional alliances that come out that will allow that. As far as whether it's better to be in a big group or a small group, let me ask you this. If you have a male age 46 that lives in Orlando, me, right? And you look at my health care claims in the next 12 months, they're going to be X dollars. So from an underwriting perspective, that's the risk of insuring me. And that risk is not going to change whether I work for a company with 3 employees, 30 employees, 3,000 employees, 300,000 employees. The risk to insure me under a Blue Cross policy is the same. Blue Cross's contract with Florida Hospital does not change. So having a large group does not change your claim cost $1. So there's really, people talk about, well, I want to be part of a large group. Actually, large groups pay a higher premium in total than do small groups. Always have, because of the way that small groups better underwrite their own people in their hiring process.
Just a follow-up question. What about rewarding health and the gamification of health as part of the large group? I think one particular Blue Cross Blue Shield player has already done that. Do you think that's going to be a trend to continue?
So you're asking if the wellness programs are effective?
No, like being part of large groups that will reward you for going to gyms and having a healthy, active lifestyle as lowering your premium cost as association with that large group.
That's available for large groups and for small groups. There are gym memberships and so forth available on both sides, but in large group, they typically have more intense wellness programs, biometrics, health risk assessments, and so forth, and they're trying to better control their costs, with some effect both directions. So it just depends upon the large group and what they're doing. There is certainly a correlation between having a healthy
employee population and increase productivity and lower cost. So to that extent that the employer can do that, they can better control their healthcare cost and hopefully increase their productivity with their business.
And my question on the small group, since the deductible that's allowable is only $2,000 maximum, now is that per family, per individual, or?
It's per individual. So
what would
$2,000 per individual, $4,000 family.
Okay, thank you.
And that's fully insured. You're going to see a lot of self-funded programs that look like fully insured programs in the small group market for which those deductibles will not apply. Hint, hint.
The ability for the business to be fined after the previous year, does that mean that startup companies have a year before they have to start offering healthcare benefits because they're not going to be assessed until the end of that year? Or do they have to start providing healthcare benefits immediately the minute they open their doors and hire an employee?
For a small group?
For a startup company, small or big, they're startup.
There's no requirement that a small group company have a health insurance program. There's no penalty if they do not. Only for 50 or more employees. Okay. And there's a whole piece I did not cover on how you measure if an employee is full-time, part-time, a variable hour employee, and so forth. There's a measurement period, a administrative period, and a stability period. And there's a whole formula on how that works. But for a new employer, if you have an employee that you think would be full-time, then you would have to get him coverage in the first 90 days.
Hi, I get offered all the time. We use paychecks for our payroll service, and they're always sending me these flyers like jump into the pool. So if you were to, or if our small business was to jump into the pool with paychecks, does that mean we change from being a small group into a large group because we're going to be jumping onto what Paychex is offering?
It depends upon how they do it, not typically. And it certainly would not change your claims any because your people are still your people. And so it wouldn't change the claim factors. But in a leasing arrangement, it might. But in a payroll arrangement, I wouldn't think so.
Told you I'm good at my exercise.
Go ahead.
You're talking about the benefit. There will be no annual benefit limits.
Correct. Yeah, there'll be.
Will that apply in any way? And don't laugh, to Medicaid and Medicare because there are currently annual limits in those programs.
Of course not. That would apply to group medical programs and only to those that have essential health benefits. So if they offer things that would not be classified as essential health benefits, then they could still have limits to those. But Medicare and Medicaid are not affected by not affected by that part of this bill. There are pieces of Medicaid that would be part of the bill, yeah.
Hey, Terry, I'm over here.
Terry, when you were mentioning age groups a while ago, you mentioned that age up to 64. Is there a particular reason why you stopped at 64? Is it because Medicare takes over, or how does that affect on your insurance?
Typically, Medicare may take over at 65. On a group plan with more than 20 employees, the group policy would still be primary and would still be part of that. But I believe that the law is 3-to-1 up to 64, 18 to 64. It doesn't include children. It doesn't include people above 64. But they cannot charge any more than 3-to-1 for the whole group. Go, Hank, go.
Get your exercise. Hi, you mentioned FSAs, but you didn't talk about HSAs. Mm-hmm. Is there any repercussion there?
HSAs, I don't believe that there's going to be any changes to those other than you've got to have a deductible limit of $2,000. So I'm not sure what the applicability is of HSAs in the small group market if you have a deductible that's limited to $2,000 per individual.
Terry, you talked about the governmental group that's being formed that's going to share the healthcare results with everybody so we would have like a level playing field. So when we have the situations where we have an illness that really doesn't have a cure at this time, but we're doing the clinical trials and we're going into the experimental treatments, will that continue?
I believe that it will. My understanding on that area is fairly limited, but I believe that the piece I mentioned there is going to only be applicable for healthcare outcomes, and they're looking at what was effective. The goal is to be able to go in to see a doctor, and doctor says, what's your ailment? You describe your ailment, and they say, okay, among people like you, your age, your gender, your health conditions, for this condition, if you do this treatment, then the results have been a 84.625 success rate. If you do this treatment, the success rate was 78.446, or whatever it is, nationally. But that's the goal, is to be able to look at the actual outcomes of different procedures and be able to communicate that back to the practitioner and to the member.
Terry, while we're waiting for other questions to come up, I have one. I'd like to know what will happen to all of the physicians. Will people be more likely to continue to go into the medical field, whether they be nurses, doctors, and others, or are we going to see a fall off on that?
Hank, I'm not sure that I'm qualified to answer that question. I'm sure there's people in the room that may be more qualified than I am to handle that. But will there be a drop-off in people in the medical profession? I believe in the free market system, and that if the demand is there, I believe that it will be, then the people will come into that field to meet that demand. It will change the pricing, it will change the compensation based upon the demand. And so I would think that would continue to be a good field to be in.
I have to ask one other question, and that is, there were folks here that sat down in their chair very early when he was talking about, on the scale of 1 to 3, how many of you know very little about this other than what you might have heard? How many of those 1 to 3s are now in the 4 to 6 range based on our presentation today? Well, I'm glad I'm not alone. A few others joined me there. Great. Are there any other additional questions as we wrap up our segment today? Well, with that, let's give a great round of applause for our speaker, Terry. Thank you very much.
Thank you very much. Questions, see me on the More Forum, or you can email me or call me.